Good evening to all of you. Thanks very much for making the time to attend this evening's session of the Academy of Medicine's Practice Guidelines Committee webinars on guideline development. We are very privileged this evening to have with us Dr. Andrea Darzi, Assistant Professor of Health Research Methods, Evidence and Impact and Anesthesia at McMaster University, to be with us today. Was there somehow okay? These are housekeeping rules. Uh, so yes, you can read that. Basically, you'll get a CME point as long as you stay on, but you have to be a fellow of the academy or a member of the academy, and you need to be logged in throughout the duration. Following the talk, you can send in questions in the Q&A function, or you could also click raise your hand, and then wait for me to call you up before speaking up about your question. So just to introduce very quickly Dr. Andrea Darzi, as I said, working at the McMaster University, um, Associate Convenor of the Cochrane Equity Thematic Group, co-leading its Equity and Guidelines Working Group, and also Assistant Director of the Michael G. DeGroot National Pain Center. She has a medical degree, but also holds a master's in public health and a PhD in health research methodology. She's an active member of the GREAT Working Group and also the Guidelines International Network, and in the past decade has led and contributed to guideline projects for Canada, the World Health Organization, the European Commission, US-based professional societies, among many others, and now leads several Canadian Institute of Health Research funded initiatives, including the Chronic Pain Recommendation Map. So Dr. Andrea, if you can enlighten us today on equity in guidelines.
Thank you, Dr. Queen. Thank you for the lovely introduction. It's a pleasure to be with you all here today to talk about equity. I will now share my slides. So today we'll be talking about advancing the way we think and consider equity across guideline enterprise. And that starts with what is equity? How do we think about it? When do we think about it? And how do we ensure that we are considering equity and we are using an equity lens while conducting our guideline and while developing our guideline that will then inform practice? So the learning objectives for today are how equity informs guideline recommendations. So how does it influence the final product? And I will be giving an example from a Canadian guideline. However, I have done a lot of adaptation efforts of guidelines to lower resource settings or to different contexts. So I will try to draw from different experiences and also think through certain experiences that may be more contextual to Singapore. Also, we'll talk about what are health inequities because we hear people talking about equity versus equality and what is the difference and which one are we talking about today? And then how do we assess health inequity? So how do we start thinking about it? How do we seamlessly integrate it into our processes? And how do we consider it? So I really like this example because it highlights a very simple thinking process that could lead to a completely different recommendation. So the Canadian Rheumatology Association guidelines, or the Canadian Rheumatology Association, they developed guidelines to manage rheumatoid arthritis with disease-modifying anti-rheumatic drugs, or DMARDs. And they had one specific guideline question. It was in people who have rheumatoid arthritis, who are in sustained remission or have low disease activity, they're on medications and have been doing well, should these biologics or targeted synthetic DMARDs start to be tapered? Should we start thinking about decreasing the dose or even stopping them completely? And why is this important? So, when they brought up this question and they thought that this should be a priority, they thought that in such populations, yes, sure, we're very happy to have sustained remission and low disease activity, but with the medications comes a medication burden and side effects. So perhaps this would be a cost-effective approach. It would lower healthcare expenses. It would minimize medication burden and side effects for the patient by trying to taper. Uh, and then they thought about what are the contextual factors, and that's a thing. When you're thinking about your question, when you're thinking about how to address a question, you want to think about what are the contextual factors that we're dealing with that are very specific to this country, or even to a specific setting within the country. And what are potential equity issues? And they recognize that you really need to have rapid access to rheumatological care in case the tapering of the medication did not go as planned. So, in order to keep it safe, you would need to ensure that there's rapid access to care. And certain individuals or populations, they sometimes have that problem. They don't have rapid access to care, and it could be because of many things. For example, in Canada, it's very widespread. So many people or populations are in geographical isolation. They are really in rural areas where it may take hours before they can actually reach a hospital or even a clinic. There's also many systemic barriers that are experienced by the indigenous communities in Canada or in other countries. Uh, there's problems with healthcare navigation for individuals that are, for example, migrant workers, for immigrants, for domestic foreign workers, for refugees. So many individuals may not be able to efficiently navigate the healthcare system and are not aware of its complexities. So sometimes they get frustrated. They may actually not go for follow-up. They may not go seek care. Another reason is economic and housing instability. So if someone is unhoused, then they may not be able to, they don't know what their situation is from day to day. They may not be able to access care when needed and as fast as possible. So this brought up the question of why tapering might not be the ideal situation for every individual. And in these contexts where we don't have efficient and effective access to healthcare, then perhaps tapering may increase the risk of side effects, the medication burden. There may be a huge disease flare, and there's no timely intervention. So patients facing inequities may experience disproportionate consequences. So when we think about care, we think about optimizing care. You want the best for your patient. That's obvious. And a lot of these things we try to think about. We already do, maybe it's very implicit in the way we think. We try to consider all of these considerations when we're talking to our patients. But here we're starting to think of them when developing the guidelines, and we're trying to make sure that we think of them every step of the way because we may not consider a certain group that is important, not out of intended harm, but really out of unawareness or not having the right people around the table that can inform us of certain groups that may be experiencing inequities. So they made an equity informed recommendation, and they said for certain people that may be unable to have rapid access to rheumatological care or cannot have a quick reestablishment of the medications, then perhaps a conditional recommendation against tapering. It'll never be strong because in certain scenarios, individuals may say, I will do whatever I need to have access, or there may, they may still want to try to taper. So there are values and preferences that need to be considered, the conversation with the patient. But here on a population level, they thought it may be wise to make a condition recommendation against tapering if you are dealing with the population that may be facing issues with access. And you know you will not be able to have appropriate follow-up with that patient. Thinking through this process helps prioritize patient safety. It helps prioritize equitable health outcomes, and it optimizes care on every level, whether on the individual or how we provide care at a population level or on a societal level. So the way we see these is that through this thinking process, you have now created an equity sensitive recommendation that makes healthcare fair and responsive to the diverse needs of everybody. Now we come to the concept of using certain terms interchangeably, and often we hear people talk about equity, but also talk about equality. And here I think it's very important that we recognize the difference and recognize why we are seeking equity. So, with health inequalities, WHO in 2012, they put out the definition that it's differences in health status or in the distribution of health determinants between different population groups. The problem with this term is that it doesn't consider whether these differences are avoidable or unavoidable. Certain differences are unavoidable, and certain differences are unacceptable because we can avoid them. There is something we can do about it. We can change policies, we can change structures, we can inform the clinical pathways that we use. So that was the problematic aspect of that term and of that definition. On the other hand, in 1992, Whitehead and group had proposed a definition for health inequities, which is talking about differences which are unnecessary and avoidable, but in addition are also considered unfair or unjust. So this adds this moral and ethical dimension to it. It means that we have a responsibility to think about these differences and seek approaches to minimize these differences or to avoid them altogether because they are avoidable. Um, they are not unavoidable or acceptable differences. And these differences, when unaddressed, they could result in a population being socially disadvantaged. So that is the reason we use the term equity instead of equality. And here I put a little editorial, a very short editorial that I was privileged to write for the GIN Journal or the Clinical and Public Health Guidelines Journal, which is on advancing health equity in the guideline enterprise. So if you want a very short blurb around equity, why we want to think about equity, where we are seeking to go with this, and how are we seeking to support the community and the guideline community with integrating equity. You can go and read that, and it's a very short paper. But here the idea is that in clinical and in public health guidelines, we aim to provide evidence-based, or I would say even trustworthy recommendations for key practice questions. And when we use an equity lens, we allow guidelines or the product of these guidelines to reduce unjust or avoidable disparities. And we're optimizing care that way for everyone. Um, and then, considering equity, it's an ethical responsibility we have because it is our job and our duty to ensure care for all and to ensure the best care for all and to do no harm. So when thinking on a population level, we really need to ensure that no one is lost in the gaps and that everyone is getting equitable care. Different groups and different countries may have different issues, but many are avoidable. So here you say, how do I even start thinking about equity? Different conditions, different diseases, different public health issues. The reality is you can start from the same place, which is who may be affected specifically in this area. We may be looking at very different groups that are affected based on the condition or disease, or based on the country, based on the healthcare structure in that country. But you can ask yourself these questions, and generally, and I'm sure a lot of you have heard of the Progress Plus. So, Progress Plus really is an acronym for all of the potential factors that may be relevant when thinking about equity. So, first, we think, are there people living in the country or in the region, depending on that guideline and what it's trying to focus on. So when it's WHO, they may be thinking globally. When it's a national entity or association or society, you're thinking more nationally. So you think of place of residence. Where is someone living? Are they in a rural area in the country? Or is that not the case? Do we not have rural areas because the country is small? In that case, we start thinking, are they living in, are they living with others? Are they housed? Are they unhoused? Are they living in an area that is accessible to transportation in case they cannot drive or they don't have anyone to drive them? We think about race, ethnicity, culture, language, religion. A lot of these may have an influence on certain interventions or your willingness or even access, issues related to stigma or to literacy, or to the way you have expectations in a healthcare system or how to receive care. Start thinking about occupation. Are there people that are unemployed? Are there people that are employed but at odd hours? They work at different hours. They cannot go after work. They cannot go during work to get care. And let's say if they're from a low income status, then they really need to work. And that means they may be going to a polyclinic or, the public sector, which may not be very flexible in terms of times they provide for care. It may have long waiting hours. There may be a burden on the physicians that are practicing in the public sector. They may not be able to work, at 12 midnight, or late in the evening or on weekends. So it is important to think of individuals and their occupations or lack thereof or working conditions that might influence their access to care. Gender and sex, not used interchangeably. We need to think of the different genders. We need to think of the different sex. We need to think of whether these interventions are affecting different genders or different sexes differently. Do they have different baseline risks? Are there considerations in terms of stigma, in terms of access, in terms of care, in terms of interactions with different medications, or the need for maybe a multidisciplinary team? Religion, I already mentioned. Education is the same. Literacy, also language comes close with that. If you're in a foreign country, if you're a foreign domestic worker, or you're a migrant worker, you may find it challenging. You may not speak the languages spoken in that country, or you may not speak them fluently. This may hinder your ability to communicate and to get the best care possible. um, Socioeconomic status, it's been mentioned. So if you're from a low income strata, you seeking subsidized care, that may be great, wonderful. You say the system is already set up for that. But subsidized care may be between 50 and 80%. What if someone cannot pay out of pocket at all? So even within lower income populations, there may be different issues and different subgroups that may be affected differently. Social capital, your relationships, your networks, are you supported? Are there people that are able to help you go to seek care? Or are you alone? Do you live alone? Are you an older individual with no support system? Um, Personal characteristics. Now that was progress. Now we're looking at the plus aspect of the acronym. It's personal characteristics associated with discrimination. So age or having certain inabilities that may affect or hinder your access to care. Maybe going to a hospital simple that does not have ramps that allow you to be able to get into the building, or they are not, there's no individuals helping to, to rush you to your clinic or to help you move from one area to another. So those are little differences that can make a big difference in someone's life. Features of relationships. So do you have smoking parents? Were you excluded from school? Certain groups that may be affected in different ways that could inadvertently affect your health and you seeking healthcare. And then time-dependent relationships, leaving the hospital, respite care, other instances where a person may be temporarily at a disadvantage. So Progress Plus, you don't need to think of all of this. You'll say, oh my God, already a guideline process is so overwhelming. There's so much to do. It already takes so much time. And now to add this, The idea is that not every factor is going to be critical in the condition and in the topic that you're talking about. But the idea is to think about these things, to do a little literature review at the beginning and to say, oh, for example, with chronic pain, unhoused individuals, veterans, women, people from the LGBTQ plus community may experience chronic pain more or may have issues with access. So we need to think about these things as we enter our guideline process and see how we can address them. And we can do that in many different ways. So myself and Omar Dewidar, we co-wrote a really nice paper, which is, a starting point. It's what are the principles that we need to be thinking about? What are the seven key principles that we need to consider when integrating or when considering health equity in the guideline enterprise from start to finish, from selecting the topic to dissemination and mobilization. And we recognize that we need to use two key things. We need an EDI lens, which is an equity, diversity, and inclusion lens, which is how we see the problem. It's a broader approach to ensure representation and full participation of different demographic groups. So here it's more about engagement of interest holders. And I say interest holders instead of stakeholders because we have moved away from that term due to it having potential colonial connotation in different areas. So the term that we have moved into, and Eliakel put out a very nice paper on this, having done a large global survey, we identified that interest holders was a more appropriate term. So that's a side note. Um, but, this is where we talk about patient and public engagement. We talk about interest holder engagement. I won't be going into a lot of detail about that today, but I will be mentioning it quite a bit because equity and the involvement of the right groups and having representation, or I would not even use the term representation because that's a heavy responsibility on one individual to represent a community, but I would say having diverse perspectives in your guideline process or even engaging diverse perspectives outside of your guideline group to gauge more people is so essential. Um, and then having an equity focus. It's more of a targeted approach where you're specifically trying to address health disparities and you're aiming to ensure fair treatment and just treatment and outcomes for everyone. And it's, we focus really on low income, or we focus on people that, are living alone or of an older age. But, certain diseases, they may be more prevalent in men, in even white men. And if they face stigma and do not seek screening, they will be at a disadvantage. So when we talk about equity, it's really not for one specific group. It's for everybody and ensuring that everyone is getting access and everyone may in one way or another experience inequity. And it is our job to ensure that we consider all of these things as we are doing our guidelines. So here you'll see the seven principles. This is a nice little figure, but it shows you that some principles are cross-cutting and some are specific to to one phase. So for example, with phase one, when you are planning and organizing your guideline, you need to know what health equity is. How are you defining it? Who are the populations of interest to you that you really need to focus on here? Versus a cross-cutting one is a priori planning. And we do this with everything, right? Evidence-based. So always plan ahead so that you're not doing things post hoc, but you already recognize the groups you need to include and consider. You include them on your panel. You send out surveys to certain groups to engage them. So when you've planned ahead at every stage of the process, you ensure that nothing is missed. Now going a little bit into the seven principles. So first we talked about defining equity and the related goals. So as we define everything else, it's important to define how we're looking at equity in this guideline. Planning from the start, we also talked about that. So proactive from the outset of the guideline process. We talked about engaging individuals with lived and living experience. So, meaningfully involving people who experience health inequities in guideline panels, in oversight committees, in advisory groups, or even part of your engagement with the patient and public community as a whole. Then we talk about evidence synthesis. As I saw, there will be a talk on, how to conduct these systematic reviews for guidelines. So from that specific aspect, even Cochrane right now we have just released two Cochrane tutorials on how to consider equity in systematic reviews, and I have put them up at a later stage, and you can take a picture. You can go in and see. So they're with Peter Tugwell and Vivian Welsh. And we conducted these tutorials because now it's mandatory to fill an equity section within your Cochrane reviews. And it's so important because it helps you from when you're thinking about benefits and harms to think, are there differences in the benefits? Are there difference in the harm profiles between different groups? Are there different baseline risks? Do I have different subgroup considerations to make here? Um, are there different implementation considerations to consider? And then it comes down to, formulating your recommendations and just explicitly considering everything that you thought about. So if you say there's different benefits or there's different harms, there's different values and preferences, all of that will be trickled into your recommendation, but not always. So sometimes you may find feasibility issues or acceptability issues that are causing inequities, or cost concerns, financial or non-financial issues that are causing inequities. As we spoke, right? Subsidized care versus not, different income levels, people living alone versus not, people facing stigma versus not, migrant workers, foreign domestic workers, individuals that work specific jobs where they cannot go during work hours, and there isn't the flexibility within the system to allow them to go on the weekend or after hours. Um, all of these things, all of these considerations that are going through your entire ETD or your evidence decision framework, they need to be considered. And sometimes they may not show up as a different recommendation. It could show up as a remark, or it could show up as an implementation consideration or a subgroup consideration. So as long as we think about them and we make sure that our final output reflects these issues, then we've done a good job in considering equity. Now, in terms of inclusive knowledge mobilization, we know that developing a guideline doesn't ensure that it's used in practice. Unfortunately, there was a BMJ paper that came out that said it takes about 17 years for evidence and for research to be used in practice. So we are still not doing well at all in terms of mobilizing the knowledge that we're learning and the new findings that we're learning into our practice. One, because maybe we're not disseminating this work properly. Two, maybe because we are bombarded with guidelines, different groups saying different things, lots of guidelines coming out, but there not being enough trustworthiness in these guidelines. And it's not up to the clinician. You're already so busy with your work schedule. It's not your job to have to sift through all of these guidelines and figure out what is trustworthy and what is not. So you have trust either in the society that tells you to use this guideline, or in the hospital that implements a specific guideline and has chosen one. So inclusive knowledge mobilization, communicating your guidelines effectively, creating plain language recommendations in different languages, in different formats. Certain people are not good with technology, others are. So finding different ways to reach all of these different groups, and ensure that they are learning and that they know they need to go for screening, or where can they seek care for a specific thing, or what kind of questions to ask their doctors. So it helps diverse audiences know how to seek care better. Evaluate equity impact. If we're doing all of this, but we're not really evaluating, well, how did this help? Then we continuously are doing this that is taking more time, and we don't know if it's actually adding any value. So it's so important, and it's a key principle that after doing all of this, that we go back and see, did it help? Did it change certain outcomes for certain groups? Has it advanced the way we do care? Are we reaching groups that we weren't able to reach anymore? What is the impact? What is the feedback we are getting? Now, this is probably a very, very familiar figure to you. This is the original and key checklist for a successful guideline enterprise that Holger Schneemann and Co. put out in 2014. Um, and we use it, we all use it in our work. And it really helps us ensure a systematic and transparent process to guideline development, and even to dissemination and planning updating. But we have recognized, and you will see that there are certain extensions to this checklist that have been published. Two specifically that I would highlight today is one on equity that we had put out, where it just helps you walk through the equity considerations a bit more explicitly, because they were not made as explicit in the original checklist. And another checklist is the patient engagement, or actually interest holder engagement in general, where it also helps the guideline developers think through who to engage, where to reach out to them, how to engage them, how to make it meaningful and less tokenistic. So this one up here is the checklist for enhancing health equity considerations. It's the Jen McMaster Guideline Development Checklist. Omar Dewidar led, and we all contributed to the development of this checklist that was really an international effort. Its purpose is to guide the systematic integration and just explicitly thinking through equity. The scope is to consider it across all of the stages and ensure that we are consistently remembering what's important and how it may impact different factors in the guideline process: values and preferences, feasibility, benefits and harms, acceptability, cost. How does it affect cost? Um, and then how to apply it. It's really applicable to all types of guidelines. It could be for regular standard guidelines. It could be for rapid processes. For example, during COVID, a lot of rapid guidelines were being developed, or living guidelines, or even adaptation of guidelines, taking an international guideline and adapting it to a different setting. And equity is even more important than ever there, because there's different considerations from one country to another, and they need to be reconsidered when they're being used in a different country. And then the implications is hopefully moving from this theoretical framework of considering equity to more practical differences, more practical implementation. This checklist includes 23 items, and it covers the 17 of the 18 guideline development topics. The link is down here, and I'm sure we're happy to share the slides, and you'll be able to access all of this. So I thought I would go through these steps in the checklist, and we can talk a little bit about how we have tried to integrate or consider equity in those steps, but also we can think through other issues, because these may not be relevant to your context. So planning and priority setting. So first and foremost, budget specifically for meaningful engagement of population. So we say sometimes we're really working on a tight budget, but if from the beginning we're planning and we ask for a certain amount of resources, financial and otherwise, so that we can involve people that are experiencing inequities. You can involve migrant workers, you can involve foreign domestic workers, you can involve people of different socioeconomic statuses, or people that actually access care. They have a certain condition and they access care privately, versus someone else on the panel you can bring along that accesses care through the public sector. And that way you're bringing two perspectives. Prioritizing guideline topics using your equity lens. So thinking about human rights and equity and explicitly involving them in the process. So one thing we did to ensure that we're always thinking about this, because not everyone knew everything related to post-COVID condition and how it might influence different groups. The Canadian guidelines for the post-COVID condition, where I was the methodologist on the prevention guideline, but the whole enterprise, we established an equity oversight committee very early on, and we prioritized including people that were disproportionately impacted by COVID-19. So they did their homework, they decided these are the groups that are mainly affected in Canada. It included racialized and marginalized groups, and those were the focus of all of our discussions. We actively thought through all of those discussions when talking from evidence to recommendation. Um, you also can set guideline priorities with your patient partners from different backgrounds. So, in all of my guidelines, whether it's in opioids for chronic non-cancer pain or other topics, we engage patient partners right from the start. And when we're prioritizing topics, we're prioritizing questions. The patient partners are involved. They're including their own questions, and sometimes we capture questions that are very relevant, or it helps us formulate the questions or the topic in a way, or expand the topic in a way that is relevant. Under Canada's here I just wanted to add that just a definition of patient and public involvement, and it really refers to meaningful and active collaboration in governance and priority setting and conducting research and knowledge translation. Really, when the patient partner becomes a part of the team, rather than just a participant, this means that you're involving them in the right way. And they really do add a lot of value. And there are studies out there by Melissa Armstrong and others that have showed through some trials that guidelines that involve patients versus not ended up having better patient important outcomes in their guideline processes, and it helped them identify topics that were not considered otherwise. Now we talk about guideline group membership and establishing guideline group processes. So here you're starting to think who's going to be on my panel, who's going to be on my oversight committee, on my advisory board as a clinical expert, etc. And it's so important here, once again, patient and public engagement. How do we involve the patients here? How do we involve people with inequities here? Include individuals in experiencing these inequities in the guideline development group. And when we engage people in different ways, it has different impacts and the processes are different. When you engage them in the panel, this is a two-way participation, right? We call this a participation strategy. And it means that people on the GDG are engaged and there's two-way influence. The patient is providing their perspective, you are communicating back with the patient, and there is shared decision making around the table. So it's a two-way ongoing collaboration where one or more patient or public members are sitting on the guideline development group, and they are helping in many different steps make decisions. And that's exactly what we did. So we established a guideline development group for the post-COVID condition Canadian guidelines that really included individuals with post-COVID condition that came from Indigenous communities that experienced healthcare access issues, and they were able to bring really fresh and important perspectives into the discussions. So now you've created your groups and your processes, and you want to identify who's your target audience, what is the topic you will be focusing on, and who are the interested groups that will be involved. So the key extension items here are that it's important to involve people. So you'll see that repetition of involvement of people, identifying who's important, and then involving those that really can help shape the guideline. And involving those people could be done in many different ways. You could really have an advisory committee, or you can put out a survey to the entire patient and public community and try to reach those individuals that may have, by doing a survey in different languages, by reaching them in different means, and try to gauge what you think is most important to them. And that way it could inform your topic selection. And then develop a process to engage them. So, as I said, you can create that by the way you reach out, by the type of material you're putting out, the languages you're putting them in out, or the processes, not only using, let's say, digital platforms, but reaching out in person, in malls, in clinics, if possible, right? If ethics approves it. So in the CAN PCC guideline or the post condition guideline, we had an equity oversight committee. So although we had for the post COVID condition guideline, we did 6 guidelines within one effort. And there was prevention guidelines and management guidelines and guidelines specifically for children and for mental health, etc. So, and for health services. So all of these different groups, we had an equity oversight committee that really came down on us and was like, did you consider this? Did you consider that? If not, go back, look for more information. Or they provided us with insight where we lacked it. And it really did help in shaping the way our recommendations or our remarks or our implementation considerations were developed. We also sought in that group, not only did we create an equity oversight committee, we also sought public input. So sometimes you involve people where there's a two-way communication, there's participation, but you also could involve more people with an outside perspective. So you do that through consultation, right? Through surveys, through focus groups where you're getting engagement. It's more one-way flow of information where the patients and the public are providing their perspectives to you for you to consider alone with your GDG. Conflicts of interest. This is a huge topic. Iliakal has published a lot on the topic of conflicts of interest, but there's an importance here, which is everyone is equal in terms of conflicts of interest. Everyone needs to be managed and considered, and we need to think of financial and non-financial conflicts, regardless of whether a group is experiencing inequities or not. And they need to be managed by the same policy. Nothing changes here. It should be universally applied to all participants. And it's important to not confuse personal or institutional conflicts of interest with people's legitimate interests, right? We all have our interests. We have our legitimate interests. No one comes in completely objective and with no bias. The important thing is that that disclosure of yours or that legitimate interest of yours will not hinder shared decision making, and you're still capable of being flexible and looking at the evidence and considering the evidence as you make a decision. For CAN PCC or for the post-COVID condition guidelines, disclosures were collected from everyone. They were considered the same way. They were reviewed using the same process, and management of those conflicts were done in the same way. Now you've chosen your topic, you've chosen your groups, and now you need to choose your specific guideline questions and patient important outcomes, which is your PICO question generation, population intervention, comparator, and outcome. And you're looking at the patient important outcomes and the values and preferences attached or the values attached to those outcomes. And here it's important that equity is considered. So you want your patient engagement again. You want to consider the groups. You want to consider domestic workers in that question, or migrant workers, or people that don't have access. So you want to consider all of these factors when you're formulating your PICO question. And you want to seek meaningful input from the people on the group, from the patient and public, to ensure that your PICOs are really valuable to everyone in the community. And we did exactly that. So we reached out to Indigenous communities and to other groups to ensure that these PICOs were reflective of everyone's needs. Here I just added a few relevant tutorials and readings. These are very new. I don't even think this is published, but has been accepted and will be published very soon in the Cochrane Evidence Synthesis and Methods Journal. These are 2 tutorials on how to integrate equity in your review. And here is a case study that we did on how to operationalize the great equity criteria to inform a medical cannabis guideline. So the topic may not be relevant to you, but the process shows a pragmatic approach to considering equity in guidelines. Now, in terms of quality, strength, or certainty of the body of evidence, it's important that you think of equity when you're looking for the evidence, when you're judging the evidence, when you're summarizing the evidence. Um, and you don't know what you find. So when we're looking at benefits and harms in the cannabis guideline, we found that in the cannabis trials, women were adequately represented, but ethnic minorities were underrepresented. So we found research priorities that needed to be addressed in that, in future research. So sometimes it doesn't have to affect the recommendation or the implementation considerations. It could highlight a research need. I've talked a lot about this, but now you've done all of this, you've considered equity. So it's so important when you're drafting your recommendation that it reflects all of your findings and that your recommendation, whether it's one or multiple, if needed, reflects the needs and perspectives of your equity deserving groups, or you attach a remark to it or implementation considerations. Also, it's important that these recommendations are revised by your patient partners, by the individuals experiencing inequities on your guideline development group. You can even share it with the public by creating plain language recommendations, and it allows them to give you feedback on clarity. So that's part of reporting and peer review. Peer review is so important, being able to go back and revise the wording and ensure clarity. And then reporting, making sure that you have plain language recommendations in different languages and that you put it on different outlets. So you want them on the website, on social media, maybe you want them in paper format in clinics, you want them in peer-reviewed publication to reach everyone, to reach all your target audience, regardless of their access issues. I also talked a lot about this around culture and language and geographical location. So when talking about mobilizing your guideline, disseminating your guideline, it's so important that you consider all of these things. Consider publishing in multiple languages or creating videos in multiple languages. Where do you post them and put them so that people that may not be digital friendly are able to also access this information? This could be done through communication. So we talked about participation, we talked about communication, we talked about one-way flow and two-way flow from either side. So different ways of engaging the patients and the public. So here I come back and say, equity, the whole idea is just to think through a lot of the implicit thoughts we already have, but to think through them in a more systematic way. Addressing equity meaningfully, having an equity expert on your guideline panel, having a sex and gender expert or an ethics expert, involving patient partners that are diverse from, that some may be experiencing inequities is so important. It builds trust in science. It builds a more inclusive environment and much larger buy-in, especially from groups that are underserved or that may be experiencing financial or non-financial barriers to care. It is our ethical responsibility and it's a practical necessity. And that's the beauty of collaboration, that no one individual knows it all. And together, collectively, we can create guidelines that are much more meaningful and that are much more helpful. And these tools are supposed to help us. Eventually, they will become second nature to us. So we're overwhelmed by these checklists, but they really just help us to learn how to think through these things. And eventually, you do it once, you do it twice, and it becomes second nature. So the Gin McMaster Equity Extension Checklist or the Gin McMaster Patient Engagement Checklist, they're grounded in key principles, and the aim is to just help developers think through things that they may otherwise not notice or may not highlight or might not recognize. And it helps make sure that the recommendations, the guideline product, the remarks, the implementation considerations, the research priorities, all of these remain relevant, they remain effective, and they remain responsive to new evidence. The evidence landscape is changing. A recommendation today is the best recommendation we have based on the best available evidence and our best knowledge. And tomorrow, if there's more equity information, if there's more information on benefits and harms, that recommendation may change. And that's okay. That's the whole aim, is to continue to evolve and create the best guidelines that we can with what we have at the time. So thank you very much for really listening through this long presentation. I hope it was helpful, and I think now we can start with questions.
Thanks very much, Andrea. I think you've given us really quite a lot to think about here. So much has been covered. I'm going to request that people would put questions in the Q&A section. If not, if you prefer to speak out, you can also raise your hand and I can call on you to ask the question directly. Uh, so just to summarize a bit about what Andrea has talked about, she's given us some definitions of equity as opposed to equality. She's talked about some of the determinants of equity that we can use the Progress Plus framework to help identify. And then she's also introduced a step-by-step checklist that McMaster Gin have developed as an extension to help make sure that you consider equity as a consideration in your guideline development. Um, I think for us, we are really quite new at this particular aspect of guideline development. I think this is really important material they've given us today. Um, yeah, so I think maybe I'll start off with a quick question, which is that in terms of, and I know you've given us examples of how you can include equity in guideline recommendation drafting and so on. Are there any examples that you're aware of where they did not consider equity, and then there were therefore consequences in terms of what was actually published and subsequently implemented?
So yes, absolutely. So there are many examples, and some of them I put in the editorial that I had put up, that short editorial. But WHO or other organizations, prior to considering equity, really were putting out recommendations that could potentially cause harm, right? But one example I can give you, which was a very interesting example, and it came up in an adaptation effort, is that there were guidelines on venous thromboembolism. They were international guidelines from the West, and these guidelines suggested that if you go, you seek care from the hospital, and then you are released directly with certain medications and a pamphlet that tells you, if you see signs of redness, if you see signs of hardness, if there's swelling, etc., pain, then come back to seek extra care or to get prophylaxis for potential VTE, DVT. But then we were adapting these guidelines with McMaster. So we did 22 adaptations of guidelines to the Saudi Arabian context for the Ministry of Health. And one thing that came up and that could cause great harm was that recommendation was releasing individuals home, because at the time many women were unable to drive on their own, and if they were living in rural areas away from a hospital, they could not take public transportation alone, they could not drive alone. Then they could have easily died, and it could have caused an increase in mortality just staying at home and not being able to access care easily. So when we did actually change the recommendation, we turned it into a conditional for staying in the hospital overnight under observation to ensure that that type of increased unintended consequences doesn't happen. So these are some of the equity considerations we think about, because otherwise you think of the healthcare burdens and you say, why keep them in the hospital? It's an increased burden financially and non-financially on the patients as well. But the reality is it could have caused a lot of mortality.
Hmm. So there really is that need to kind of like try and look beyond, what is on the printed page and thinking about the impact of all these recommendations and whether they might have these kinds of effects to subgroups of the population.
Absolutely. And I'll say I understand the frustration of many because there's not a lot of equity evidence out there. So they say, well, even if I search for it, I won't find it. But that's the beauty of having experts or diverse perspectives on the panel. That right now, we don't have the best evidence in equity, but we do have diverse perspectives. We do have these engagements that we can make with the patient and the public to try to consider these things throughout our guideline process until we have better evidence.
Okay, well, we've got one question in the Q&A. I think I'll just read it out directly. Clinical practice guidelines are tough to create at national level because it can be used as legal documentation of the standard of care in some disciplines, e.g. oncology. The literature is changing very fast due to new emerging data. So how often should guidelines be updated? So not directly a question about equity in the sense that this actually applies, to all aspects of guidelines. But maybe we'll see what Andrea can make of it.
Yeah, no, I think that's an excellent question. And it definitely, as the evidence evolves, also equity evidence evolves that may need to be reconsidered, right? So I think that's an excellent question. And it really depends on the topic. So, for example, if we're looking at, during COVID and post-COVID, trials were coming out every day, thousands of studies were coming out monthly. So if you say, oh, we're going to use the cutoff of 3 to 5 years before we update a guideline, that would have been terrible in that area because so much new evidence was coming out that really it needed to be living. A decision was made to be living. While now, maybe it's trickling down and there's not as much evidence. So they reevaluated and they said, okay, it doesn't need to be living anymore, but maybe we can reassess yearly or every 2 years. So it really depends on your topic and it really depends on the area. Is there a new medication? Is pharma releasing a new product or intervention? Is there a shift in that area and the way that you treat that is causing a lot of new studies to come out? Or is it an area that before you didn't have good evidence and now so much better evidence is coming out? So before you used to wait 5 years to update, but now you feel like, no, we need to, there's huge trials that have just come out. So 2 years later, you decide it needs to be updated. So you need to have that communication at a national level with the right individuals, with different interest holders, and make that decision by observing the evidence and how fast it's coming out.
Also, perhaps useful to remember that when making recommendations, you don't have to always come up with a very definitive statement, especially if the evidence doesn't support it. So don't forget, besides making strong recommendations, you can also make conditional recommendations.
And the beauty of conditional recommendations is it allows the physicians to undergo shared decision making and to think of the individual in front of them and individualize care. So people love strong recommendations, but conditional ones I find are more flexible and they give you the liberty to really consider the person in front of you.
Hey, are there any other questions for Andrea? I thought I might have seen a hand raised, but I don't see it now.
I do have my email up here. I hope everyone feels very comfortable to reach out with any questions. I'm always happy to answer what I do know. And if there's something I think I'm not an expert in, I will absolutely find an expert that can help you.
Well, we very much appreciate your expertise this evening, Andrea. Yes, and we will be sharing the slides. So those will be available as along with the recording of this talk within the AMS learning system, where you can see all the past talks that have been given, actually recordings of all the past talks. So before moving on, I'd just like to ask if everyone can please also scan the QR code for the feedback form and give us feedback for this evening's session. That form also includes possible topics for subsequent webinars. So do also suggest topics that you'd like to see covered within the realm of guideline development or implementation. Um, and I would like to inform also that we do have speakers lined up for several sessions going, especially into next year as well. Next month's session in particular would be of great interest, I think, to the local audience. because we've got a representative from the Agency for Care Effectiveness from the Ministry of Health who will come to talk about their recently launched guidelines for guidelines and how that might impact on non-Ministry of Health guidelines. So I think that would be quite an interesting session. They've come up with 9 standards that guidelines should meet in order to be considered trustworthy. And I would suggest that, if you can, tell your friends, especially those who are currently working or planning to work on guidelines, and encourage them to attend next month's session on the 26th of November. And we're reverting to the usual 6 p.m. Time at that point. Okay, so I guess at this point, oh wait, we've got a hand up. Hold on. Dr. Lee Chun Hong has a hand up. Can we can we unmute him, Ira? How do we do that? Ira, are you there? Can you help with unmuting Dr. Lee Chun Hong so he can ask his question?
Perhaps Dr. Lee could try from his end to unmute. Is that possible?
We have allowed him to unmute.
Hello.
Okay, there we are. Go ahead, please.
Hi, everyone. Thank you very much. I think this was such an enlightening talk for me. And I never thought consensus guidelines could have such an interesting dimension. And I hope that in future in Singapore, as we continue to work on guidelines, we will keep these very important points in mind. Thank you very much, Dr. Andrea.
Thank you. Thank you very much for your kind words.
Thanks very much for your comments. All right, so if nothing else, then we have gone past the hour. So that kind of like only leaves me again to thank Andrea for her contribution. And yeah, we'll see you next month.